Good morning and welcome to the 7th Annual Minority Health Month Community Breakfast, Breaking the Silence, Facing Dementia in Communities of Color, Meeting the People Where They Are, and continuing the dialogue on inclusivity and research. My name is Gina Green Harris, and before we get started, I want to let you know that we will be recording this meeting today. I have to share with you that this is an educational event is being recorded for the purposes of online learning for addressing health disparities in communities of color. This recording will be accessible on our Wisconsin Alzheimer's Institute Regional Milwaukee office website. And again, I want to say thank you for coming. Greetings, good morning, and welcome to the 7th annual and first virtual Minority Health Month breakfast addressing Alzheimer's disease. I want to share with you that this morning and welcome my guest moderator for the day, Mr. Lou Holland, who will be joining me today as moderator. Good morning, Lou.
Good morning, Gina, and thank you so much for having me here today, and thank you so much for all you do at the Wisconsin Alzheimer's Institute and the work that you do to serve our communities. And today, welcome everyone. Welcome to this 7th Annual Minority Health Month event. If I can, let me give you a little background on this whole concept of the Minority Health Month. In April 2001, the National Minority Health Month Foundation launched National Minority Health Month in response to the Healthy People 2010. The U.S. Department of Health and Human Services Health Promotion and Disease Prevention Initiative, National Minority Health Month received support from the U.S. Congress in 2002, with a concurrent resolution that a National Minority Health and Health Disparities Month should be established to promote educational efforts on the health problems currently facing minorities and other health disparity populations. It is well past 2010's initiative, and our communities continue to suffer from health disparities. As many of you already know, dementia impacts communities of color at an alarming rate. African Americans are 2 times as likely, Latinos, Latinx, 1.5 times as likely to be diagnosed with some form of dementia. Today, we have come together again to break the silence about this disease and educate our entire community as we learn how we can collectively work together to help our loved ones navigate the dementia journey. We hope that today is a day of learning, hope, and refreshment. And we know this is not the end, it's just another step on our journey and along our pathway. So Gina, I'm gonna kick it back to you.
Thank you so much, Brother Lou. And before we get started even more, I want to thank you so much for sharing the purpose for why we're here today and reiterating that this is Minority Health Month. And this is a month where we are definitely looking at Alzheimer's disease as a public health crisis. And I just want to do a quick overview of what we're going to expect today. But I want to share, as Lou has said, we've been working on this for several years, and none of us expected that this would be a webinar today as we are hosting the 7th annual event. When we first planned this event, we hoped to see everyone in person and have our breakfast as usual and do great work in person. But as life would have it, as pandemics would happen, we have to go on, and we understand that due to the tribulations that have been going on this last year and a half, things look different. But that doesn't mean the work doesn't continue. And so what we've had to learn to do is stay on the wall. We've had to continue the work because so many lives depend on what we do every day. Everyone who has continued this journey, whether you work with people directly or indirectly, you have had to identify new and innovative strategies to get the work done as if the lives of our community depended on it, because they do. And we are no different. We have continued to work tirelessly to make sure, even more now, that our families receive adequate services, that our families are well listened to, and that we're advocating in these rough times right now of social injustices that we know are rising to the top. We are continuing to advocate for equity, health equity, social justice, and basically making sure the basic principles of life are met for our families and our community as a whole. We have had to learn that in the worst of times, the best outcomes can be possible. The ideas, the visions, the dreams, and innovative strategies were forced out of us in these rough times. And so we must continue to dream and dare to be different and dare to continue to work our mojo and be the change agents that we are called to do, because to whom much is given, much is required, even in the worst of times. So I'd like to quickly share with you a brief update as to how our team has continued to do this work, even throughout this pandemic. I want to share with you the work of the Amazing Grace Chorus. The chorus has continued to meet virtually. Our families needed this service to continue, and under the leadership of Stephanie Houston, we continue to build our community through song. The Amazing Grace Chorus has had multiple meetings virtually and singing virtually, and we're continuing to build on the strengths and the assets of the community to make this program thrive. The Amazing Grace Chorus's spring session will be February 27th through June 25th, 2021. You can visit our website at wai.wis.edu/chorus/chorus to not only download the flyer, but learn more about the Amazing Grace Chorus. We are excited that Stephanie has continued to serve these families. And I want to make a note, this is more than a singing chorus. This chorus provides care and support to families and do wraparound services as needed. So if you're interested in learning more, please reach out to Stephanie Houston. But we have continued because, again, our community depends on our work. We've also had to switch our format of work into doing more virtual things. Again, recognizing that just because of the pandemic, the family needs did not stop. So we are inviting you to join us for what we've created called Coffee and Chat, where we are actually sharing information about how to stay safe during COVID, how to stay mentally well during COVID, and how to continue to learn more about Alzheimer's disease and other health topics, important health topics that are relevant to our community during this time. You will see that there's a flyer up, and we have information about the upcoming coffee and chats. They are Zoom videos, and if you have questions about that, you may reach out to Gail Morgan, and her information is on our website. Again, wai.wis.edu/Milwaukee, and Gail's number is on the screen. I want you to know that we are continuing our research initiative. We are ramping that back up, and we are focused again on the Wisconsin Registry for Alzheimer's Prevention. Our goal is to continue to recruit and retain African Americans in this study. And so if you want more information about the RAP study, you can contact Selena Ramsey. And her phone number is also on this flyer. We are committed to making sure that we are here and present for our community. Now, having said that, we thought it was really important to share with you that the work is continuing. We continue to serve our families. At this time, I'm going to tell you the overview and then share with you who our sponsors are for today. We will see Brother Lou Holland has given us the statement of purpose for today. We will certainly begin to talk about our Village Awards. We'll highlight our sponsors, and we'll hear from Dr. Jonathan Jackson, who is our guest speaker today. Many of you may have heard him in Breaking the Silence in our last session, but we were so overwhelmed with requests for him to come back. We're excited he's joining us today. And then we'll end with closing remarks, but not before we have Brother Lou come back with a call to action for where do we go from here. At this time, I'd like to thank all of our sponsors, and I want to give a special shout out to Brother Lou Holland. Mr. Lou Holland has been one of our strongest supporters and contributors to the WAI, our work over multiple years. Whenever we ask, he shows up, and he's very supportive of us, even with his financial contributions, but more importantly, his spirit is with us, and we honor that as well. So we want to thank you, Lou, publicly to say you and the Holland family, we are just indebted to you. Two other sponsors that we want to acknowledge that have been strong supporters of our work specifically is the Bader Foundation. Bader Philanthropies has been the start with the WAI Milwaukee since its inception and the WAI since its inception. And we want to give a shout out to Helen Ramon of Bader Philanthropies, our program officer, who has supported our work in and out, who has opened doors for us to leverage the funding that we have. We want to thank you for that, along with thanking the Greater Milwaukee Foundation for its contributions and our program officer, Darlene Russell, for making sure that we are constantly in the know and making sure that the contributions are continuing to support this work. But we could not do it without all of our sponsors, and we want to thank every sponsor that is listed in front of you today. We know for sure that these wonderful sponsors and sponsorships are really significant as we continue to do this work for our community. So we also want to thank one of our special sponsors, the All of Us Research Program. And Dr. Bashir Easter, who is a new PhD that we want to acknowledge, is here today to share a few words with us about the All of Us Research Program. Dr. Easter.
Thank you, Gina, and good morning, everyone. There are tremendous health disparities in the African-American Latinx community. These communities are also two of the groups of the people who have been left out of research in the past. In some cases, research experiences have been detrimental to the ethnic communities, as we talk about the Tuskegee and Henrietta Lacks in our history. The All of Us Research Program aims to build the largest, most diverse database of health information in its kind that researchers can use to study health and illnesses. We want to support researchers in efforts to understand how different genetic, lifestyles, and environmental factors impact health and disease. With this information, researchers can look to improve the ways to diagnose, prevent, and treat health conditions. This could lead to improve in health and illnesses and treatment for generations to come. The goal is to have 1 million people to participate in the All of Us Research Program. People who join will share information about their health habits. Also, they'll be looking to do surveys, donate blood, urine, and saliva samples as well. By looking for patterns in this information, researchers may learn more about what affects people's health. If you're interested, we would like you to do more research for yourself. Please go to joinallofus.org to learn more about the program. And once again, thank you very much, Gina. We're looking forward to hearing more and all the work that's being done. We're breaking the silence. Thank you very much.
Thank you so much. And we certainly appreciate all of the work that is being done through the All of Us Research Initiative in the state of Wisconsin and across the country. At this time, we are going to now switch and transition in our program to share our Lou Holland Senior Village Awards. These awards were started about 3 years ago. And these awards are recognizing and acknowledging people from our community who have contributed and shared part of their life helping us combat and fight Alzheimer's disease. And at this time, I am going to share with you who our 2021 honorees are for the Lou Holland Senior Village Award. And again, recognizing that Mr. Lou Holland Sr., and yes, Lou Holland Jr. is his son, was a dynamic leader and contributor to our world, actually, through his life. And his son, Lou Holland Jr., has taken that legacy on and has continued to honor his father, who passed away from Alzheimer's disease, a form of dementia. And so he has been a consistent partner with us on this journey, especially as it relates to African Americans on the journey of Alzheimer's disease. So in honor of Lou Holland Sr. and in honor of Lou Holland Jr., we are excited to have been able to create these awards to recognize community members who are also helping us on this journey. I want to acknowledge our honorees, our Miss Janet Mays, Miss Kimberly Ramsey, Mr. Brian Peer and the staff of Get Us ROI, and Miss Sharon Jordan of Direct Supply. I will begin by sharing just a few words about each of the honorees this year. The honorees of 2021 include 2 amazing caregivers and software companies with the mission of courageous excellence to do the right things. So let me begin with the first recipient, Miss Janet Mays. Janet has been on the caregiver's journey for some time, first with her grandfather, followed by her aunt and uncle. Janet's stepfather, who was diagnosed and passed away from Alzheimer's disease, and now Janet is helping to care and support for her mother and her brother, who are both living with cognitive impairment. Janet's caregiving journey has led to her to connect with programs like the Wisconsin Alzheimer's Institute Regional Milwaukee office, where she has participated in caregiver workshops, community forums, and outreach programs. Janet has shared her caregiving journey to encourage others to connect with local programs in the community. In the spring of 2020, Janet, along with her stepfather, James, and mother, Ella, were all featured on the National Alzheimer's Association magazine, The Music Issue, where she shared her struggles with caregiving and how music and singing in the Amazing Grace chorus inspired and provided her with support. Thank you so much, Ms. Janet Mays. Our next honoree, Ms. Kimberly Ramsey, reminds us all to remember to take care of our veterans. Kim's journey as a caregiver began with her father, Mr. Mac Ramsey, a U.S. Army and Korean military war veteran, was diagnosed with Alzheimer's disease. Kim knew that there wasn't a cure for Alzheimer's, but she was determined to seek out local resources for her dad as well as for herself. It was at the Clement Zablocki Veteran Administration Medical Center where Kim learned about the Adult Day program known as the Vets Club. She enrolled her father into the club for socialization and to begin to seek out other local resources for support. She worked with the local dementia care specialist to obtain respite services, and she and her father participated in the WAI regional outreach programs. Kim's own experience of assessing resources for veterans motivated her to speak out at every opportunity for more resources for veterans and their caregivers. More resources for those who have valiantly served our country, Kim says. Kim's father passed away in July 2020, but she continues to use her voice and social media platform to share resources with other caregivers and professionals. Thank you, Ms. Mays, and thank you, Ms. Kimberly Ramsey, for your work as caregivers, and we honor you. Our next Lou Holland Senior Award recipient is Mr. Brian Peer and the staff of Get Us ROI. Get Us ROI is a software company who turns their company success into opportunities to reach out to help others. The company's ROI team is made up of individuals from all over the world, all sorts of cultures and religions and family heritage. While the company believes that their diversity makes them a stronger team, they never forget that many things that binds them together. As stated in their company's mission, they have a strong desire to do the right thing, and thinking about others is always the right thing to do. Each year, Get Us ROI recognizes the work of nonprofit organizations and those who seek to improve the lives of others. Since 2017, the WAI Regional Milwaukee Office Amazing Grace Chorus Program has been a recipient of the charitable gifts from the support of the ROI team. The company's donations has helped to sustain the chorus program, which improves the quality of life and participants and caregivers through socialization, music, and education to assist and connect with dementia and Alzheimer's care support groups and research. Today, it is our turn to do the right thing to recognize Mr. Brian Peer and the staff of Get Us ROI LLC as one of the recipients of the Lou Holland Senior Award. Brian is the son of Bill and Joanne Peer, who have been members of the Amazing Grace Chorus since 2017. Thank you so much, Brian and staff at Get Us ROI. Our final recipient is Ms. Sharon Jordan of Direct Supply. Over the last several years, Ms. Jordan has made it her commitment to ensure that the chorus members of the WAI Amazing Grace program have been recognized in the community for the work and trailblazing work that they're doing as folks who are living with dementia and singing in our communities. Not only has Ms. Jordan advocated for resources to support this particular breakfast that we're doing today, or this particular webinar now, but she has also made sure that the Amazing Grace course has continued to receive support from Direct Supply, whether it be performing at the Summerfest grounds during the senior days or doing other activities. And Ms. Jordan has also made it her business to make sure that the Amazing Grace course and folks with dementia have a seat at the table when looking at community groups, as she has asked our team members to be participants in the community advocate group that she leads at Direct Supply. Ms. Jordan has a motto in life that says, if you think you're too small to make a difference, try to sleep in a closed room with a mosquito. And she definitely also says, my challenge to everyone is to try to make a difference while the book of life is still open. Thank you, Sharon, for really making a difference and your organization for families who are living with dementia. And we want to thank all of our participants. We want to thank all of our honorees today. And we sincerely look forward to working with each of you both now and in the future. And at this time, I am going to turn the floor back over to my dear colleague and to my MC host, Mr. Lou Holland, who will now introduce our keynote speaker.
Thank you, Gina. And before I introduce Dr. Jonathan Jackson, I want to say on behalf of my family, on behalf of my dad, Janet, Sharon, and Direct Supply, Kimberly, Brian, and the staff of Get Us ROI, thank you for all you do and representing our community. And it's truly an honor for you to, from my family, for you guys to win this award. So thank you for all you do. And I wish I could be there to shake your hands and thank you personally, but please know my heart is reaching out to you on behalf of my family to say thanks. All right, it's my great honor to introduce Dr. Jonathan Jackson. Jonathan is the director of the Community Access, Recruitment, and Engagement Research Center, also known as CARE. He does this great work at Mass General Hospital and the Harvard Medical School. CARE investigates the impact of diversity and inclusion on the quality of human subjects research and leverages deep community entrenchment to build trust and overcome barriers to the clinical trial participation. His research focuses on midlife and late life health disparities in clinical settings to affect underserved populations. Dr. Jackson also works as a cognitive neuroscientist investigating the early detection of Alzheimer's disease, particularly in the absence of overt memory problems. Jonathan is an amazing speaker, and I welcome him to our program today. Jonathan.
Wow, okay. Thank you so much, Brother Lou. I appreciate that warm welcome, and I am so glad to be back here among all of you today. You know, I do wish it was in person, but I'm hoping that we'll find a way to be all in the same space again, usually, hopefully sometime in the near future. So I presented here at Breaking the Silence 2 years ago. I was in person and it was a wonderful time. What I am here to do today is to give you a kind of a partial update. So 2 years ago, I made a lot of wild promises, and I told you a lot of things that you know, that I was planning on doing, and how we were on the cusp of a new world order in the sector of clinical research. One where communities like yourselves, where people of color would have true power and true initiative. I am here above all other things to tell you that that transition has happened. It has happened because of COVID-19. It has happened because of George Floyd and so many others, including Breonna Taylor, and some of the same nonsense that we're going through again this week. But it is time, I think, most appropriately to start meeting people where they are in research. It is time to break the silence. So this talk will be focused on empowerment. We'll be focused on the nature of the problem and what it is that we all need to do about it to work together. Before I begin, and just like I told you 2 years ago, you got to start with the disclosures. I've been very blessed to have some grant success over the last 2 years and to be able to raise some funds so that we could do our best but poor imitation of Gina out here in my native or in my hometown, Boston right now. So we have a bunch of community activities that are supported by a number of foundations. This money is completely firewalled from the rest of the operations of our center. They don't go to support anyone's salary, any administrative roles, and certainly not our research. These are dollars that go directly into the community. We also have had some really great luck in terms of research support. So we are supported by multiple institutes and centers from NIH, as well as a long-standing agreement and multiple awards from the Michael J. Fox Foundation, and a new award from PCORI that just went into effect a couple of months ago. Let's start with a little bit about who I am. This is me a little under 35 years ago. And one thing that you got to know about me is that I'm pretty relentless. I worked really hard for a long time to get where I'm going today, or where I am today. But, you know, I want you to know that I am here not for my own sake, not to kind of toot my own horn or talk about the research that I've done or you know, any important grants or anything that I've got. I'm here to actually talk to you about the past. And I think we have to start with AAIC, which is the world's biggest conference that's dedicated to Alzheimer's disease. And in 2017, that conference was in London, believe it or not. So it was a really fancy experience. This was 2 years before I met all of you at Breaking the Silence. But this is where our story starts. And it is honestly the most important thing that I'm going to tell you today. So listen close. I was at AAIC in 2017, and there were more than 5,000 researchers there that year. And they get together every single year to discuss the latest advances in diagnosis and management and treatment for Alzheimer's disease and also for other kinds of dementias or dementing diseases. It sounds fancy that I was staying in London for a week at this very fancy conference, but the reality is that I had spent all of my money paying for the flight and the conference registration, which was over $1,000 for just the conference registration fees alone. And the truth is I was too broke to eat most days. I had enough money for like 4 meals over the course of the week. And it was a really rough time. What was ironic was I was working at my dream job in 2017. I was tenure track faculty at Harvard Medical School. I was working in a cutting edge research lab led by one of the most brilliant and dynamic and influential researchers living today. But I was feeling pretty disillusioned about all of this. So, you know, while work around Alzheimer's disease has dramatically accelerated in the last 10 years, and public participation in clinical trials is still one of the hardest parts. It's one of our largest barriers to a cure, and especially for communities of color. We know that these same communities of color have been historically exploited in the name of medical advancements, and as a consequence, ironically, these same communities of color, those same ones that all of you work in and represent today, now they're routinely ignored, while medical advances now test and primarily benefit more privileged populations. So what you see is, and what was on full display at that conference in 2017 was there is a fundamental inequity in access at the clinical trial stage. And that has driven these ballooning health inequities between white people and everyone else since 1980. And although this problem has been really well established for for decades, for more than 4 decades now. Scientists are pretty clueless. Like we don't, if you talk to any scientist, they'll tell you we're right on the cusp of curing Alzheimer's disease. I've got so much hope. But when it comes to talking about racism and disparities, they're like, whoa, 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 that's way too complex. But at this conference, I met Gina Green Harris. She got up on stage in London and she had that smile that she's always got on her face. And she presented one of the most incredible and effective and powerful academic talks that I've ever seen in my life. It stays with me to this day. So Gina summarized a plan that she had designed and worked on and executed and for over a decade. And it centered the needs of communities of color in Milwaukee and around Wisconsin as a primary driver of research engagement. So I just want you to imagine that for just a few seconds, half a world away. Gina brought all of the love and the support and the energy of you all here in Wisconsin and changed the lives of many people in that room today, and I'm certainly one of them. So she made it very clear that research innovation was contingent on community building and empowerment, rather than what you still see today, like empty gestures and gimmicks and half-hearted promises that have always been part and parcel of the way that researchers do business. Gina argued that sustainable scientific progress has to center social justice, and especially social justice for marginalized and disenfranchised communities. She had such an elegant presentation that had a number of success metrics and frameworks and models. And again, it was really one of the most formative moments of my entire life. Like I said, I was working at my dream job. I had spent 10 years trying to get into that lab. 6 months later, I quit. I quit that job to open up my own research center in pursuit of the same questions and in pursuit of those same ideals that Gina presented in 2017. So now I'm the director of the Community Access Recruitment and Engagement Research Center at Massachusetts General Hospital and Harvard Medical School. The name's a bit of a mouthful, so we just call it CARE, but we focus on improving access to clinical care and research through using inclusive design and basing it on community entrenchment. And I assure you, we would not exist without Gina Green Harris. Wouldn't exist. So, like all of you that are on this chat, that are in this Zoom today, I go where Miss Gina tells me. That's why I'm here today. And I hope that those of you who are more local and more proximal to where Gina is continue to value and elevate this woman, because I've traveled the whole country and there is no one like her. There is no one working at the level that Gina is today. You know, as scientists, we often talk about something called the research life cycle. And one of the very last stages of this cycle is something called prestige. You know, the idea that somebody has to benefit from this work that's being done. What I want to say is that Ms. Gina works tirelessly so that all of you, no matter what stakeholder group you represent, all of you benefit. And usually what we see is her bosses get the credit. They're the ones who get the prestige. They're the ones who get the grant dollars. And because now it's fashionable to be in the community. So I'm here today to urge all of you to set that record straight. We are all here because of Gina Green Harris and her team. And I hope that throughout this silly research life cycle that she is given the proper credit where it's due. And so this is the first step. The reason why I'm saying this is because this is the first step of how we meet people where they are, by ensuring that our tireless women of color are truly recognized for their contributions and their creations. So if you have to fill out an evaluation today, if you have to tell your friend or an auntie about these sessions, about what you heard today, don't talk about the university or the Wisconsin Alzheimer's Institute or me. Talk about Miss Gina and what she's done for over a decade to bring us all into this Zoom today. So that is the most important thing that I'm going to say. I used to study mind wandering, so if you check out for like the next 40 minutes, you're totally fine. Just remember the work of Gina. So now I'm going to start my actual talk here. I'm going to start with the past. Not often given to quoting other people, but sometimes it's just better to honor the wisdom of others. And here's the quote: "Of all forms of inequality, injustice in healthcare is the most shocking and inhuman." Martin Luther King said these words to a raucous crowd in Montgomery, Alabama, after a long and exhausting and violent and deadly march from Selma. At the time, he was primarily referring to contemporary issues around health and race, but he was also talking about medical abuses against the Black community, past and present. In particular, Dr. King was talking about a study that had just come to light, which was the Tuskegee syphilis study. It was known about well before it was written up by the New York Times in 1972, but it was a shortcoming of the civil rights movement of the 40s, 50s, and 60s to actually get the study shut down. Sometimes things don't really exist until the New York Times publishes about it. So what we have to remember, and what I want to tell you about today, is not to necessarily go down the road and talk in detail about Tuskegee. I've got another talk for that. If you want it, I'm happy to come back and give you detailed information. But what I want you to understand is the fallout from the Tuskegee syphilis study. It's not something that we often talk about, but there were massive changes made in the research world in the wake of Tuskegee, with the idea that these kinds of things should never happen again. But it's certainly my argument that while the solutions presented after Tuskegee solved a lot of problems, they created some other ones. And in order to kind of illustrate this point, I've actually got a little movie clip from a Nova special that was published in the early 90s, interviewing people who were involved in the Tuskegee study. So there were many survivors of Tuskegee, but they also interviewed one of the study doctors who, even in the 90s, was not sorry. And let's hear a little bit about what he has to say. This is John Cutler.
One of the few surviving public health service doctors who worked on the study still defends that decision. John Cutler.
It was important. They were supposedly untreated, and it would be undesirable to go ahead and use large amounts of penicillin to treat the disease because you'd interfere with the study.
So there you have it. The reason why Black men were denied penicillin treatment for 40 years is because it would interfere with the study goals. And what we have here is, I think, a very clear indication of what feels like cartoon level villainy. However, if you talk to researchers today, if you ask them, why can't you reimburse somebody for lost wages, for taking half a day off work to participate in a research study? Why can't you take care of a child care costs or elder care costs? Why can't you bring somebody in at 6 p.m. after they get off work or on a Saturday? The answer is very similar to what you heard from Dr. Cutler here, because you'd interfere with the study. Well, we don't have the money for that. We don't have the time for that. And so while it's really difficult to imagine something like Tuskegee happening again in the United States, it is much less difficult to understand this kind of justification because you'd interfere with the study. That still lay very much at the heart of clinical research today. And this is why I'm talking to all of you, because it's time to break through that reluctance. It's time to demand better. And I think under the guidance of powerful women like Gina, I think it's time to kind of make that leap forward. Now, I would be much remiss if I said that the Tuskegee syphilis study was the only major egregious abuse against Blacks. I showed you the same slide 2 years ago and let you know that there are a number of other abuses that happen. And again, I do have a whole talk that goes into detail about these and others. If there is interest, I'd be happy to come back, hopefully in less than 2 years, and give you the full rundown. But what's important is not necessarily to dwell on these abuses in and of themselves, but rather how those abuses have given rise to the current climate of healthcare disparities. There's a strong connection between abuse and neglect. And I've actually got another video clip here from Vox and ProPublica that talks about the link between these historical disparities and the current the new kind of abuse that I think is enshrined mostly in things that you see here, differences in infant and maternal mortality.
In a lot of ways, SIMS epitomizes the story of American medicine for Black women. It's a system that's failing them to this day. From infant mortality to life expectancy, the racial disparities in healthcare are staggering. The gulf between Black and white might be widest when we look at maternal mortality, with Black women 3 to 4 times more likely to die in connection with pregnancy or birth than white women. And that divide can be traced back to doctors like SIMS, who contributed to a long, largely overlooked history of institutional racism in medicine.
Trying to understand a historical problem without knowing its history is like trying to treat a patient without eliciting a thorough medical history. You're doomed to failure.
And so that quote right there at the end was by writer and scholar Harriet Washington, who is definitely one of the most dynamic and fascinating medical historians living and working today. So, a couple of her talks are recorded online. I highly encourage you to check her out. Fingers crossed, I'm trying to get her to give a virtual presentation for us here in Boston in a couple of months. And if I'm successful, I'll pass along that link to all of you. Now, the reason why I'm talking about this climate of disparities is because we need to understand the broader context of these awful consequences of health disparities in the healthcare field. Now, here I'm going to present a figure that I've had in my talks for a long time, and I think what's horrific is how timely and relevant it continues to be. So what I'm doing here is I'm going to plot the number of Black lives that are taken by police shootings versus those who die from diabetes. As you can see, it seems like the graphs are kind of close to each other. What you're seeing is that like the diabetes deaths are a little bit higher than the police shootings. But one thing that you also need to note is you need to look at the legend. What we have here are the fatal police shootings that are tracked on an annual basis. So this is the number of Black lives that are taken by police every year. What we have in the green is, we see on the right-hand side, are the number of Black lives that are taken from diabetes alone every week. So what we're talking about here is a green line that is 52 times higher than what we see in terms of these egregious actions by the police is absolutely dwarfed with what we see in terms of just deaths from one disease. This isn't talking about the number of people whose lives are affected, those who have to undergo some kind of horrific treatment or amputation, those who are living and suffering from other diseases. This is just diabetes for just a week. And we're silent about these kinds of disparities. And we know that in the past year, in March of 2020, we were all in this together when it came to COVID. April of 2020, we started to realize that some of us were being affected more than others. And so this is a tweet that that was published by the Wisconsin group, I think just yesterday, that talked about looking at COVID disparities for Black and African Americans in and around Milwaukee. And so as you can see here, like if you're looking at some of these regions where there are more Black and African American folks living, they are disproportionately affected by this disease. So the solution must be that we have to be more involved in the regulation and the development and the advancement of healthcare. And that process starts with clinical trials. Now, I'm not trying to encourage everybody to run out and sign up for a research study right now. It's just that we've got to be more involved in health research for our own sakes and for our own lives. But I don't want to express that thought lightly. Let me tell you a little bit. I'm just going to pause my my sciencey story and tell you a little bit more about what I've experienced and why I'm still saying all of this. So while working on my doctoral degree in cognitive neuroscience at Washington University, I spent about 6 years in St. Louis, where I personally, individually, was frequently detained by the police for the unfortunate crime of being Black near an affluent institution. I was detained by 4 police officers who thought I had stolen my own bike. I was detained by police officers trying to go to the airport. They thought I had stolen my own bag. And this was in the years before the world had heard about Michael Brown or the Ferguson Police Department. But my experiences, even back then in St. Louis, made it clear that no matter what I had been told growing up, I was Black first and everything else second. So I'm not here to say, that it's important to be involved and get involved in clinical research and clinical studies because I am naive and because I have not experienced these kinds of things. I really have. And honestly, I have never been made more aware of my Blackness than during the 8 years and 4 months, but who's counting, that I've lived in Boston. This is the city that's in a northern state on the East Coast. Oftentimes well-meaning white liberals, and maybe some of you on this Zoom know the feeling, well-meaning white liberals demand that I speak on behalf of my race because they are desperate to build up credibility with their equally misguided friends or funding agencies. And these are the same folks who slap me on the back and ask how proud I am that America defeated racism when Barack Obama gained the White House. It's funny because some of those backslaps have stopped since around November 2016, and they've gotten a little bit quieter in the last year. I'm not quite sure why though. Maybe some of you know. These people in Boston are the same ones who use words like microaggression and white privilege and white fragility, and they use them as weapons and epithets to be directed as others rather than as tactics that they themselves are unconsciously promoting. Black men ask me for the dates of my next talk, not because they think that the information is compelling or relevant or even good, not because I'm a good speaker, but they just want to show that, these are Black men that want to show their Black sons that it's possible to be more than a rapper or a jailbird or an athlete or a statistic. I'm not really any kind of role model, but I am a Black man with a degree and a good job, and the people of Boston never let me forget it. So when I say that we've got to find our way in this sector of healthcare and clinical research, it's with a clear idea that this system is broken and abusive, and it feels hopeless most days. But here's what's going to happen if we continue on as we do. This is a graph of big data. These are genotypic and phenotypic databases for major areas of research as of 2018, published by a good colleague of mine, Latrice Landry at Harvard Medical School. And so what you can see here is that these are data that's supposed to represent the whole world. These are the data that are at the heart of projects like All of Us. These are the data that will guide and shape the next 5 to 10 decades of medicine. And what we see here is that the population with maybe 16% of the global population routinely serves, contributes 60, 80, 90% of the data that you see in these large databases. We're here to talk a little bit about Alzheimer's disease dementia, which is represented by the neurologic category here. As you can see, neurologic databases are more than 80% European, which is another way of saying Western European and white, non-Hispanic. When we have Asian here, we're not even talking about all Asians. We're talking about Han Chinese. And then as you can see, the orange bar that's supposed to represent underrepresented groups, it's not here at all. There's virtually no representation in neurologic databases of people who look like me, people who look like many of you. And these are the data that will go on and power novel immunotherapies and artificial intelligence and new algorithms. If we're not here, then we're not anywhere. So today, I want to talk to you not just about this problem, but the problem of recruitment and engagement in clinical research. And a lot of it is governed by a little known law that actually has nothing to do with diversity or race or anything like that. It's just the way that we do business as researchers. And it's known as Lasagna's law, and I've got it right here. It says, the incidence of patient availability sharply decreases when a clinical trial begins and returns to its original level as soon as the trial is completed. And so I've actually sprinkled in a few GIFs in my presentation. This is another way of saying this. We as researchers are horrible at trying to figure out who's going to come into our study. So we will wildly overestimate. And then when the study begins, we'll rapidly revise that number. And then when the study ends and we're running our next grant, we'll go with that huge inflated number again. We're going to get all of the brown people into our research. But the truth is, we often tell ourselves and each other that it's time to downsize our expectations. But so why does this happen? Like, why is diversity even important for clinical research? Why should we care about this? Is it just like a social justice thing, or is there something else going on here? Turns out that 20% of FDA approvals have some sort of differential exposure in terms of race or ethnicity. And so it's really important to think very carefully about who's affected by these different kinds of drugs. A really clear example of this 1 in 5 rule has been seen just this week with the Johnson & Johnson COVID vaccine. We have therapies that are emerging from Pfizer, from Moderna, from AstraZeneca, and unlucky number 4 is Johnson & Johnson, and we see that there's a differential rate of exposure response. Instead of being as a function of race, in this case, it may be a function of gender. It seems to disproportionately affect women. And so we know that this happens over and over and over again. And this is a part and parcel of the way that we develop new drugs and therapies in the United States. And we've got to do better. We know, and I just showed you a graph on this, that where we are doing the worst is in whatever therapy or whatever technology is the most advanced. So talking about precision medicine and algorithms and AI is where we have the worst levels of representation. And then for those of you who understand a little bit more about clinical research, we know that it's just about trying to find ways to be very sure about cause and effect. And if we are not careful about who's involved in our research studies, we're going to mess up our ability to tell, to kind of understand that cause and effect sort of reasoning. So I want to give a concrete example of what happens if we can't recruit representatively. And I use this term very, very precisely. I'm not just talking about diversity or diversity inclusion, I'm talking about representativeness. And when it comes to Black Americans, when it comes to our Black lives and dementia, it is a big old mess because we have not recruited representatively. So if you think about, and this is a slide that I presented to all of you 2 years ago, we know that Black Americans are about twice as likely to develop dementia as whites. And so this paper is pretty old, it's from 2001, but lots and lots of other research studies have pretty much backed up this finding. So it doesn't seem to be a problem of testing bias, but the big question is, does this really represent any kind of justice? Does this mean that Blacks should continue to be neglected and forgotten in the research space? Well, it turns out that a paper that's a little bit older than this one, that was published in the mid-90s, shows that it's not all Blacks that have a disproportionate risk. It seems to be African Americans. And what I mean by African Americans are those Black identifying people that seem to be descended from enslaved Africans. So we can see here that for Nigerians, there's not really an increased risk of dementia, but for African Americans, for those of us who have my kind of heritage, which gets a little murky in the mid-19th century, we see that there's a risk there. And it gets worse. If we look at the research that we published, this is an older paper of mine from 2017, we can see that we have these measures of subjective cognitive concerns. That's when you ask somebody how their memory is, and then memory performance when you actually test someone's memory is. These things are associated with each other for white people. For Black and African Americans, there's no correlation whatsoever. So what we have here is we've designed an entire system of understanding, diagnosing, differentiating dementia that is powered only for white people. That's where we are right now. And so there is this increased risk, but we don't know why. Our best test is useless, as you can see here, by comparing that blue line, which is just basically flat, versus the red line, which gives you that nice association between a test and what you ask somebody how they're feeling. And what I'm going to do next is I'm going to present one of my favorite figures. It's a little bit complicated, but it's homegrown. It's from the folks down the road over at Madison. And this is published by Carrie Gleason and her colleagues, which shows something called a Kaplan-Meier curve. All you need to know about this curve is the steeper the line means that the faster somebody or the faster a particular group is progressing to some level of additional risk. So as you can see here, the red line is steeper than kind of the bluey green line, which in this case seems to suggest that white people are much more likely to progress to dementia than Black people. But if you remember what I just said, you might agree with Stacey Abrams here. There's nothing about this that makes sense. We know, based on all the other stuff that I said earlier, that Black people are supposed to have that higher risk than white people. It turns out that in this study, which has 4,000 people in it, we were not thoughtful about being representative. We got all of the white people from a memory clinic, where, of course, if you're coming to a memory clinic, you're much more likely to have memory problems. All of the Black people came from community settings. They came from events like this one, where, yes, there may be some people who are at risk for suffering from dementia, but there's going to be a lot fewer than somebody pulling, individuals coming from a memory clinic. So what we've got here is, this is one of our largest data sets in the dementia space, and we've got it exactly backwards in terms of understanding risk, because we have been so bad at recruiting people of color into our research studies. And so you can actually, really break down the problems here. There are so many peer-reviewed manuscripts across every discipline, but there's no definitions, there's no data frameworks. It's really, really tough to replicate and measure all of these problems. We don't even have a good definition for what a minority is. And we don't have good definitions for what the difference is between outreach, recruitment, retention, or engagement. We don't know how to do any of this. And there's no infrastructure to support us. So there's no experts, there's no tools, there's no resources that are available or generalizable or scalable. And if you have a study team, they don't get to spend all of their time on engagement and recruitment, even though it's important. And when we do have detailed engagement protocols, when we do have detailed recruitment protocols that focus on people of color, they are literally separate documents from the rest of our study design. And that's a problem. And so I think what we have here is a big old mess. We as scientists created the mess in the first place. We tried to fix it. We're making it worse, and we're getting things really confused when it comes to understanding the risk of dementia for white people versus Black people. We don't really know why. We can't get the right people into our study. It's like comparing apples and oranges. You might feel like Chrissy Teigen. I've given up, but maybe not entirely. And so this is where we get into some of the work that I've been doing at the CARE Research Center. So if you plot out, if you go back and do the work and look at all these old papers, you find out why we can't recruit diversifully. And it turns out that it's usually due to about 10 different reasons. And so the problem is, if you are running a study, and you're a big fancy researcher, you're a principal investigator, also known as a PI, you know that some subset of these 10 are affecting your research, but you don't know which ones. You have like $4 to spend on this. Where are you going to put your $4? It's really hard to know. So what we've done at the CARE Research Center is we developed a workflow approach. And 2 years ago, I presented this workflow for the very first time at a little event called Breaking the Silence. And it turns out that it's actually been very, very helpful. So what you can do is you can take, so these are slides from 2 years ago. You can take these top 10 reasons and you can map them directly onto this workflow. And so what this workflow approach tells you is where you need to start, where bottlenecks might arise, and where you can invest your resources, because none of us have an infinite amount of money and time to fix these problems. And so you can see some of these top 10 reasons might be split along multiple areas of the workflow. Some of the areas of the workflow might encompass multiple sets of barriers, and on and on and on. So instead of just having a top 10 list of reasons, you can create a really strong workflow approach. So this is a reimagining of what the research workflow looks like. With all of those barriers that we see, they're better weighted and prioritized. So what we traditionally consider to be the research workflow is just what you see in this red box. We don't have a clear science or approach or mechanisms to understand. We don't have protocols for the rest of the stuff outside of the box. We have so much to work and to learn and to do here. But I want to talk to you just through a couple of examples where we've leveraged this framework. But before that, I'm going to tell you another story. Now, one big question you might have with this fancy triangle that I'm presenting is whether it works everywhere. Like I told you that I'm currently in Boston. I spent a bunch of years in St. Louis, and I've gotten a few flavors of racism, but I originally grew up on a farm in rural East Texas, right here at Ben Wheeler, Texas, which is where that red star is. The farm was just outside the town limits of Ben Wheeler. And so it's so small, Ben Wheeler is so small that they don't really count the population on a regular basis. So we just assume that there's somewhere between 300 and 400 people in town. Now, the residents of Ben Wheeler are outnumbered 20-1 by feral hogs. And every year they crown a hog queen at the annual Feral Hog Festival. So y'all know that only a town full of crazy Texan white folks would go around dressing like this. This is an actual picture of one of the Feral Hog Festivals from a few years back. So I attended a school so white while I was growing up in Texas that many classmates and teachers just referred to me as Black Boy for an entire year. And my brother, who's a year younger than me, his birthday's on Friday, was nearly brought up on drug charges for daring to take his asthma medicine during school hours. And so, and then, on top of that, as I got older, because my friends and my enemies growing up in Texas, they said that because I knew who my dad was, because my family was just above the poverty line instead of just below it, because I speak like I do now and I make good grades, that I wasn't Black at all. So I know racism from many angles. And to return to our topic today, we want to ask a question of who's getting this right and does it matter where they are? It's clearly not happening in Boston. So, and St. Louis is starting to see some change, which is wonderful, but, and obviously not the lovely folks here in Ben Wheeler. So we asked this question in a project called ADNI, the Alzheimer's Disease Neuroimaging Initiative. And here's what we ended up doing. So we looked at 4 places, Emory University in Atlanta, Kansas University in Kansas City, Rochester, New York. We looked at Los Angeles. So the question is, who's meeting people where they are? And so what we ended up doing was kind of plotting this little spider chart that you see here. And you can see, like a place like Emory is doing great on community engagements and partnerships. They're probably second only to what Gina's built here, which is really saying something. But then you also see sites like Rochester, which is, they're not doing a whole lot here. What is interesting is that in this ADNI 3 protocol that is being run at multiple universities around the United States, Rochester is repeatedly one of the top enrollers. They're just not top enrollers for Black people. So what we ended up doing was trying to plot all this together. And what we ended up doing was trying to identify that bottleneck, that upside down triangle that I highlighted earlier, to see where sites like Rochester did compared to a site like Emory. And what you can see here is Rochester was able to reach out to some African Americans in the greater Rochester area, which is pretty diverse. But as you can see here, of those who they actually were able to reach out to, they could only engage 18%. And then they didn't recruit or enroll anybody. By comparison, what we see here in the Emory sample is they were able to reach a whole lot more individuals, and they were able to keep them engaged and keep them involved. So they had a deeper approach for their engagement work. So even though you've got 2 sites that are generally regarded as really good at recruitment in the Alzheimer's disease space, it's very easy to see when you plot using this triangle approach, what Emory's doing relative to the other ones. So what I wanted to do is also talk a little bit about Michael J. Fox and his wonderful foundation. So the Michael J. Fox Foundation realized that for people living with Parkinson's, it was really hard to achieve any kind of diversity in the field. Because not only do you have to have a diagnosis of Parkinson's, which is hard to get, You have to go and see like a subspecialist. So you can't even see a regular neurologist. You have to see a movement disorder specialist. So they launched the study Fox Insight to really make sure that they were able to reach out to a diverse and inclusive and representative population. And so they said, you know, this is an online study. All you need is a phone or a laptop. All of you could sign off from my talk right now and go sign up for Fox Insight. There's nothing stopping you. It's free. And so they came to me in 2018 because they were having some problems with the representation in their study. And it looked like this. So for those of you who may be looking on a small screen, don't worry, it's white for a reason. At the time, it was the population that had completed the study and was sticking around with the study was almost 90% white. It's not just race and ethnicity. If you looked at income, these individuals, mostly the average income was over $100,000 a year. You know, most people had not just a bachelor's degree, but most people had a master's degree, a PhD, or an MD. So this is not a representative population, or Bernie Sanders put it best by saying, this ain't great. So what we ended up doing was we took this framework and we focused on these top 4 areas. And we looked at 8 sites around the United States. All sites got to pick a barrier that they wanted to solve. You know, within this framework, they picked a population that they wanted to reach and a very specific intervention that would relieve this barrier for a given population. And so we gave $45,000 to intervention sites, $10,000 to control sites. And another little known fact is we decided which sites would be intervention and control 5 minutes after my Breaking the Silence talk. I don't know if any of you were there and remember, but I ran outside and had a meeting on my phone, and it was to actually figure out which sites we were going to assign to which conditions. So this happened in Milwaukee 2 years ago. And so what we found here is something that was pretty remarkable. So relative to their own baseline, so we looked at how sites were doing before we started our Fire at PD study, and then during the Fire at PD study, and that's what you're seeing here. So relative to their own baseline, we're not seeing a whole lot of diversity. But intervention sites were able to improve enrollment for this Fox Insight platform for people of color, for low-income individuals, and for individuals of relatively low education. Even control sites, which weren't supposed to be doing anything, also saw some improvement in diversity. So this is one example of how to break the silence. This is how you meet people where they are, by focusing on the barriers that the community is already telling you that they're facing, and then allocating resources to fix it. It's not that complicated, but I think people have struggled to measure it. The other main, I think, finding from this was developed by former research fellow and new assistant director of the Care Research Center, Dr. Angie Sanchez, who developed this participant barriers dashboard. So instead of just tracking the people that signed up for the study, we also looked at who wanted to be involved but couldn't. And we tracked the reasons why they said they couldn't participate. And so many people think, that participation in research for people of color is driven purely by trust, mistrust, low trust, no trust. But it turns out in this particular study, the biggest problem was language equity. People wanted to be able to fill out these surveys and they wanted to sign up for Fox Insight, and they wanted to do it in Spanish. They wanted to do it in Chinese or Russian, but they couldn't. There was an issue with the digital divide. And so when we provided tablets to each of the sites, then time issues became a problem. Who wants to hang around in a medical center during rush hour and to fill out, like 45 minutes worth of surveys? Nobody wants to do that. So trust was a factor, but it's barely on the scoreboard here compared to all these other issues. Now, I'm going to wrap up my talk in just a few minutes here, and I wanted to say another reason why I'm here today, and this is because of Dr. Andrea Gilmore Bikowski, who has also been absolutely transformative of the work that I have done at the Care Research Center, and she has been a voice of calm and reason and support through many, many years and many, many projects. And I can say that, this is another woman of color who we need to cherish and support and promote, because without her, I think we're all pretty lost. So the last piece of advice that I have for you today is based on a recent project that I did with Dr. Gilmore Bikowski, and it concerns thinking about the 3 principles of the Belmont report. So for those of you who don't know necessarily what the Belmont report is, after the Tuskegee study, and its direct response to Tuskegee, the Belmont Commission was created in 1974, and they issued their final report in 1979. And the recommendations had basically these 3 pillars: the respect for persons, beneficence, and justice. Anybody who ever does any kind of clinical research to this day knows about these 3 pillars. And this is supposed to be kind of the heart of how you engage in research today. But the truth of the matter is, we're not doing a great job with this last one, with justice. So, Andrea and I, along with super duper star Consuelo Wilkins, put together a paper last fall that talks about thinking about this concept of justice. And we had 6 main principles. Number 1, there are already regulations and policies on the books. We just got to enforce them, that make it possible and make it necessary for researchers like me to go out and make sure that people are involved in research in a representative and diverse way. We need to make sure that we are addressing the barriers that make it hard to participate in research. One of the simplest things that I think is one of those problems where you'll get Nobel-winning doctors who will shrug their shoulders and say, I don't know how to solve this very complicated problem, is why the vast majority of our research participants have to speak English. There is nothing about Alzheimer's disease that is restricted to English speakers, and yet the bulk of our research requires it. And so that's exclusionary. That's a problem, and we need to fix it. So we need to end these practices that exclude on the basis of what's convenient for us as researchers. We have to move beyond proportional representation. We don't need to represent diversity at the level of census tracts. So just because Black people are like 12.8% of the population, that doesn't mean that you need 12.8% Black people in your studies. That means that you need to focus on disease risk or burden. So, when you saw all of the data talking about how diverse the COVID-19 vaccines were, they were comparing it to the level of census tracts, but they should have been comparing it to the burden of disease, where we saw that Black and brown folks were developing, they were suffering, they were hospitalized and dying at rates several times of that of white people. And yet we still couldn't get these folks into research. That's a problem. So we need to move beyond proportional representation and focus on powering our research for disease risk or burden. Again, this is not just for social justice, it's for the sake of our science. Principle 4, we need to build sustained reciprocal relationships with marginalized communities. This is where all of you lovely people come in. We need to stop centering goals on individual researchers and institutions. Remember when I talked to you about that prestige factor? That prestige factor, 99 times out of 100, goes to researchers and institutions. We are awarded millions of dollars because we are able to sweet talk a couple of people from the community. The communities should benefit from that. And I think that the time is now that if you are working with researchers, there should be a benefit for you in addressing the research question and being paid for your time and in having an opportunity to own the data and rent it back out to the universities. There needs to be a centering of the goals on communities themselves. And researchers, for those of you who are in the audience, don't lament mistrust. Make sure that you are trustworthy before you do any complaining. This next bullet point is how I'm spending my life lately. Again, thanks to Gina Green Harris. To develop sciences of research participation and inclusion and what that might look like. And then finally, that we need to recognize that there is a key connection between research and health inequities. Without justice in research, without solving these problems that we see in clinical trials, we will not solve the problems that we're seeing out in the streets, with people dying 52 times the rate of police brutality, from diabetes alone. So we can only address that by addressing this problem of research. And so one of the last things that I want to kind of leave you with is a better way of understanding what we mean when we talk about this concept of disparities. I've used this concept so many times. I've used this word so many times in today's talk. What do I even mean about that? We should be talking a little bit more about justice, as Dr. Gilmore Bikowski wrote in her paper from last year. So I want to just break down what I mean. Historically, all differences that you see between groups, between men and women, between white people and Black people, they were all kind of lumped into this term of being, centralized biological disparities. And there's this underlying assumption that they were somehow inherent, they were immutable and unchangeable. So Thomas Jefferson himself said, never bleed a Negro because they can't handle it. And it was just part of their essential nature. We're still doing that in academic medicine to this day. So it's not only incorrect, it's unjust, and it places the blame at the feet of those who are most vulnerable. We saw this with COVID-19 right at a year ago when some of those disparities by race first emerged in the data, and people were saying, I wonder what it is about their Black skin that makes them so much worse when it comes to COVID-19. They made it our fault. Nowadays, I think some of us in the room understand that while there may be some biological differences between groups, social inequities drive some of the differences that we still observe. But I think it's important to recognize that even this framework, still leaves a lot to be desired and often puts the blame and the onus on vulnerable, underserved, and marginalized groups. It's still y'all's fault. So what I propose is that we actually think of disparities is a bit more complicated, and it looks a bit more like this. And so what you see here, especially with the 3 arrows on the left, is a deep reconnection with domains where we as researchers now, we have the ability and the responsibility and the culpability when it comes to assessing, modeling, and limit these kinds of biases. We know that these things creep into our research and they taint the conclusions that we attribute to social inequities and biological disparities. So, to kind of contextualize everything that I've said before, that I've talked about, in the way that we normally think about disparities, most people, when they talk about disparities, they're really talking about these 2 things, and maybe a little bit of this one. And I've actually got a paper coming out a little bit later. Everything that I presented today has really been focused on these 2 guys, things that researchers can and should be doing to meet people where they are. And so I wanted to just talk about one last example. This is my second to last slide, about how to do this right. So I'm working in a large clinical trial network called EpicNet, which is focused on pain management. In fact, right after this talk, I had to go back and finish a grant to actually pay for a lot of these activities that I'm about to talk about. So EpicNet stands for Early Phase Pain Investigation Clinical Network. And so it turns out that what you need to do is you need to centralize some of these activities and localize some of these activities to really make sure that you can drive long-term, sustainable, diverse, inclusive, and representative recruitment to these pain management studies. So what that means is you're thoughtful about each of these stages of the workflow, where you have a brand identity campaign to make sure that people know who you are, which is something that we as researchers don't think about nearly as often as we should. We need to have localized partnership activities at the local level, at the level of the site, where people can connect with the community and the community can directly benefit. We need to have site selection protocols where we only recruit people into the network if they can deliver on building strong relationships with communities. We can also do even more than that. We can be thoughtful about combining recruitment and feasibility analyses when we're creating the network itself. We can center the patient voice and give them a leadership position, as well as develop focus groups to allow them to weigh in on research studies as they're coming down the pipeline. We can look at data burden and make sure that we are designing studies that benefit the people that we're studying in some way, shape, or form. So in order to do this right, you got to do a lot of things. You have to make sure that some things are centralized, some things are flexible, but ultimately, this is possible to do. So this is how you break the silence. This is how you meet people where they're at, by giving them power, by giving them structure and a voice to tell you what they need. Because this is the only way that we're going to achieve rigorous science. But I'm gonna leave you with one final thought from the words of the immortal MC Hammer, who wrote this on Twitter back in February. When you measure, include the measurer. And that's my talk. Thank you so much.
Jonathan, fantastic, as usual. And you made me look like I was a genius when I said you're one of the most amazing, dynamic presenters that I've seen. And I really appreciate you coming. And we have another thing in common. I go where Gina tells me to go as well. So when she says go, or you need to be on this Zoom, I am here. So you and I got that in common. So thank you so much for all you're doing. Thank you for all the stuff that your CARE network is doing in the East Coast and bringing a little bit of that out to us in the Midwest. And the things that you had spoke to today, to the audience who are listening to this call, I can't thank you enough for all you're doing in the fight against dementia, in particular for our communities. So at this time, I am going to, Gina and I are going to transition. So Jonathan, I hope you can stay on. I know you said you had a grant to write, but I'd hope you can stay on. And I'm
going to stick around for a while. Yeah, I'm here.
That'd be great. I'm going to go into the chat feature, and I want to remind the audience that are here today that if you have questions, Gina, Jonathan, and I, if I can, but primarily Gina and Jonathan, would be happy to answer those questions. And so there's actually, it looks like on this, two features. There's a Q&A feature and there's a chat feature. I'm going to jump into the Q&A feature because there is a question that says, can you talk about the successes in outreach? What works well? How do you define success in a meaningful way versus a quantitative way? So Gina or Jonathan, can I ask one of you to address that question?
I'm happy to give kind of the detailed sciencey answer, but I think I would rather speak after Gina because she's the one who's doing this better than anyone else.
Yeah, so yeah, thank you for the question. And before I answer the question, I want to just salute Dr. Jonathan Jackson, who's a brother, and Lou's comment. Thank you so much, Jonathan, for presenting today. Thank you for the kind words and the acknowledgement of the work that not only I, but the entire Alzheimer's Institute Milwaukee team does. It's the teamwork that makes the dream work. And so the team really pulls us together. So we would not be here without each other. So I'm appreciative of all that they have done with us to follow the vision, to put the vision and make it work. So no man is an island when you're successful. So I do want to acknowledge that. Thank you for that. But to answer this question now, the successes in outreach, what works well and how you define success in a meaningful versus quantitative way. So what works well for outreach, quite frankly, is for us, it was moving from the ideal and concept of outreach, right? Where you're just outreaching people, but backing it up to saying, what is the difference? Then comes the word engagement. You don't just do outreach for success. You have to engage community members by hearing their voice. Everything you talked about today, Jonathan, where you are looking at the community, not as a deficit, but from the assets of the community and engaging them, talking to them, recognizing that before you see their illness, before you see their race, before you see the downside, you need to see humanism in people. And you need to understand that there's always someone who has a touch of wisdom. People have been living with their angst for their entire lives. And that's what we build on. We build on the strengths of the community, of the people. Yes, there are high volumes of disparity, but everybody is not in a disparate condition. That's what we tend to miss when we start generalizing communities, as opposed to going in and recognizing there's multiple layers of diversity that exist within our communities and tapping into those folks and community members as resources, not for our science, but for their benefit of how to have and continue to expand healthy living overall. That to me has been one of the biggest things that we have done to have success. And we also recognize that it was more important for us to have community first. And what I mean by that is, yes, we know research is critical and it's very important, but for many of our community members, research was not the priority. That's the school's priority. That's the institution's priority. That's the investigator's priority. The real priority for the community is, how do we live, thrive, and not just survive? How do we actually engage our community so that when we leave, if we have to go, that whatever we've gotten started stays and the community continues to benefit. So it was more than numbers on a sheet. It was actually hearing community members say, you guys are here for us. And I will drop this nugget too. Oftentimes investigators think because you're giving money to a community. Say you're going to write $10,000 in your grant, which you will then eat up by saying, oh no, I got to pay for this for the staff. I've got to pay for this for my this or that. You've already eaten that money up. But even if you do could put $2,000 down for an event and you don't show up, well, you really haven't supported the community. You just outreach, you haven't engaged. And that's a real difference in the work that we try to do. So I'll stop there, Jonathan, and you can take over.
So I'll have you all know that it was exactly this topic that Gina was speaking about in 2017, where she was talking about this asset-based framework for the first time. And it was, I think it was published, the paper that you wrote was published in 2019, right?
Yes. Yes.
And so that I think is the best way to think about it. And I just want to piggyback off of your last point there, which is, really drawing a distinction between outreach, engagement, recruitment, retention. They're all different things, and they have different people who care about them in different ways. But ultimately, if we are centering the community, the only way to define success in a meaningful way is if the community benefits. And if they benefit at every step of the way. So whether they sign up for a study or not, whether they read your newsletter or not, if they are benefiting in terms of their health, their well-being, their prosperity, that's meaningful success. And if you do that well, all the other stuff that you're looking for is going to come to you. They're going to want to hang out with you. They're going to want to help you get yours. But you have to center the needs of local folks first. So somebody wrote in the chat that the community knows exactly what they need and want. All we got to do is listen and be a little creative in how we're designing our studies. It's possible. I've done it. Gina's done it. It's not rocket science, but it does require that we work hard, that we listen, and that we be thoughtful in centering the needs of people outside of the ivory tower.
Yeah, that's well said. And, being thoughtful, being able to listen and engage the community is what it's all about. There's one other question that I see in the chat. And I think, Gina, this is more for you. Where can I get info and resources on making a decision on whether my dad should take some medication for onset dementia?
Absolutely. So there's a couple places where you can look for information. We actually have a very strong diagnostic clinic network that we have put together that under the leadership originally of Dr. Mark Sager, where there were clinic networks established specifically for that question, getting folks a good diagnosis and understanding how to access those services for your loved one who may be on the dementia journey. So I can recommend that you look at our website, which is wai.wisc.edu/. You can use the Milwaukee site, or you can actually look at the clinic network site. That the front slash would be the clinic network. But I also want to tell you that our program, Stephanie Houston, who's in our office, actually works directly hand in hand with families who may need a good diagnosis. And Stephanie can definitely help you by asking questions, but connecting you with the clinic network. One of the unique features of the programs that we do is that with our program, we actually engage the clinics as a whole, and we have Stephanie who works with those providers to go in and out and into those families' homes to actually help with diagnosis and then care service thereafter and support service after. So I think that is where you start with the clinic network. And I think it's really important to recognize, I was just looking at the data from the Alzheimer's Association's new 2020 facts and figures, and it said that 50% of the physicians do not believe that they have the access and the ability to continue to diagnose dementia effectively. And so that is huge. And we have to Jonathan's point, we've got to work on that as well, preparing our medical staff to be able to answer these questions. And again, we know the facts and figures say that 1 in 3 folks who elders will develop dementia, but that number is increased for African Americans. We simply have to do better around culturally training our providers to be culturally inclusive and culturally centered, to know how to get folks of color a good diagnosis and then into good care thereafter. But we're certainly here to help you. You can call on our website. I think Cindy Carlson, director of the WAI, put the website for the clinic network in the chat. Thank you for that, Cindy, and we certainly can help you with that.
Okay, thank you so much, Gina, for that information. And it appears that there are no more questions on the, oh, wait, here's one. Actually, it's just a thank you and love it. Positive language, engage versus outreach, live, live, thrive instead of just survive. Well said by one of the participants. So Jonathan, again, I want to say thank you for being here today and for your amazing presentation and your words regarding our community and how we can best engage. You are a true treasure to the work in the field of dementia. So thank you so much for being here. We truly appreciate you.
Yeah, I look forward to coming back if you'll have me.
Well, I tell you, you mentioned a couple of your presentations. I'd be down for that. So anytime you want to come back, Gina, make it happen. Yeah. Tell him he needs to get back on get back on Zoom. I would say get back on a plane, but I think that day is over for a little bit anyway. So Jonathan, thank you so much, my friend. Ladies and gentlemen, I just want to kind of sum up some of the things that I heard today. It's about community. It's about working together. It's about adjusting to one's needs and ideas and thoughts. It's about getting involved. And one of the things that I have always believed in, especially as my dad went through the journey, is if it's not me, then it's who, And so, I have looked at my life and the things that I have done over the course of my life as I maybe said this before, I look at it as I have 3 T's. I have my time, I have my talent, and I have my treasure. And for me, all 3 of those T's are in. They are in the fight against dementia. Now, I'm a volunteer like most of you who are watching this Zoom webinar. So that means I have another life outside of this. But this is so important to our community. And so however you look at your 3 T's, however you can allocate one of those T's with Gina and her team and in the fight against this dementia and in our communities, only you know what that is. But for me, I'm hopeful that today in this Breaking the Silence event will cause you to think about how you can get engaged and how you can help. Jonathan outlined a lot of the issues in past research for African Americans and Latinx. I would throw that in the bucket as well. But if we're not in these programs, our data doesn't show up on the charts that wonderful doctors and scientists like Jonathan show. And so for me, all 3 of my T's are in. And I'm hopeful today, this presentation, this program gave you some thoughts to potentially put 1 of your T's or 2 of your T's or all 3 of your T's in the mix. It's truly been an honor for me to work with the Milwaukee, Wisconsin Alzheimer's Institute. My family, my father's family, is generated from Southeast Wisconsin, Racine, Kenosha. So this is near and dear to me. And so for all 170 folks here, I thank you for allowing me to spend some time with you this morning. Gina, I'm going to kick it over to you.
Thank you so much. I just want to say a few things, and thank you, Lou. Without you, I got a few minutes here, and I'm going to thank Jonathan too, but I want to say this about Lou. When I first met Lou Holland, it was just a brother from another mother, and many of us can understand that. But what I mean by that is his sincerity, his commitment. As he said, his 3 T's are real. And many times people talk about their time, their treasure, and their talent, and they do this fallacious talk, but Lou was real. And we want to thank you, Lou, your family. Whenever you guys answer when I call, and I want to thank you for that. I thank you for showing up, because some folks will pretend like they didn't see me calling or they lost my number, but you don't do that. And I want to thank you for that. And that means a lot to us. You've helped mentor our program. You've helped mentor us. You've helped really make sure that the work that we're doing in Milwaukee is recognized. And so we just honor you for that. And Dr. Jackson, Jonathan, you're my brother too. And I want to thank you guys for really 2017 in London when we met, and when you talked about that, what was interesting is that you don't know how much you helped me and our program grow. And so I want to thank you, and thank you for continuing to that flame and acknowledging where your inspiration came from, because many folks get there but forget how. And so thank you for that. And today was just amazing. And yes, you know you're booking us again, so you will definitely be back on whether it's webinar or hopefully in person. We definitely appreciate you and we'll have you back. You are such an asset to all of our work that we're continuing to do. And however we could be of benefit to you, please never hesitate to call on us. So I want to thank you both for all of your time and support today. Now, as I transition us out, because I know we're almost at the end, we I want to try to share my screen and see if I can. We do want to acknowledge. Let me do this real quickly here. Here we go. We have a young lady who has. Can you guys see that? Many of you might know Nia Norris. Nia, you can turn your camera on so people can see you. Nia Norris has been with our program since its inception as well. She came to us as a graduate student at Marquette University at the time. And we knew she was bright. We knew she was brilliant. She had graduated from UW-Madison and went to Marquette, but she came as a graduate student. And when she and I met, she talked about her family history of Alzheimer's and dementia and the passion that she had for this work. Well, Nia has been just a brainchild behind a lot of the things that we do. And she has been the right hand and the left hand between, when we first started, it was me, her, and Stephanie. But Nia has gone on to grow in her own professional way, her academic way, and quite frankly, in her work. And so Dr. Norris, now Dr. Nia Norris, as of 2 weeks ago, we want to give you a token of appreciation, Nia. Nia is the brain behind today. She arranged this, but we're so proud of you, Nia, for completing your PhD, and we know you're destined for future greatness. You've got so many milestones with us here. Your beginning, since the beginning, you kept me organized. I got to own that publicly, and we wouldn't be where we are today without all of your love, your support, and your commitment to this work as well. We look forward to your future and continuing to serve the community with you, but we also look forward to lifting you up and advancing you and your work as you move forward with your new career path as a new doctorate, PhD doctor in the field that you have selected. So this is from myself, the full team, from Steph, from Gail, from Selena, Ian, and of course, Navina. We want to honor you, bless you, and say thank you, thank you, thank you. So, to you. So
thank you so much. I am so humbled and grateful. Thank you so much for this. This is a wonderful surprise, and I see the chat. Just really grateful, and thank you so much. And everything I'm doing is to serve the community, and so I'm just so blessed and feel very humbled to be here. So thank you all.
You are so welcome. And again, we look forward to all that you're going to do. Thank you to our audience for attending. I'm going to shift us because we are moving towards the end. You can visit our website at wai.wis.edu/Milwaukee to stay updated for our activities and programs and upcoming events. I would like to also ask you to please, please, please complete today's evaluation. I believe the link will be emailed to you after the event, but please complete the evaluation and share with us what you thought about today. We are always looking for ways to improve, but this, again, keep in mind, is our first time doing this by form of virtual form and a webinar. But we sincerely thank you for your time, for your effort, for your energy. We thank you for your treasure. Congratulations to all of our honorees this year. Thank you to Dr. Jackson and to Lou. We want to salute you. Thank you to the staff, the WAI Milwaukee staff, Ian, Selena, Gail. We want to acknowledge you, Stephanie, for all of your work and contributions. We are all the team that makes the dream happen. And I will leave you with just one word, a couple words, and that is from my dear favorite poet in the whole world, everyone knows, you may write me down in history. So you may write us down in history with your bitter, twisted lies. You may trod us in the furry dirt, but still, like dust, we shall rise. Out of the huts of history's shame, we rise. Up from a past that's rooted in pain, we rise. We are Black oceans, welling in sighs. We understand that we are the hope and the dream of the slave. Now, I did my own Gina version, but at the end it says that I rise, you rise, we rise. As people of color, we continue, despite all the challenges, we continue to rise. So I salute you all and say, rise, rise up, continue to move forward in all that you do. Be blessed, be well, and thank you so much for attending.